All right, let's dive into a topic that's, well, pretty high stakes in nursing. We're talking about something that really puts all our skills to the test: safety, pharmacology, and, yeah, communication. It's a big one.
So I want you to think about that for a second. What area of nursing really forces you to bring your A game in all those different areas at the same time? It's human sexuality, right? And all the incredibly sensitive issues that come with it.
And let's be really clear about why this matters so much. This is not just about being nice or making someone comfortable. This is literally about life and death. If we miss the subtle signs of intimate partner violence, if we don't create that safe space for a patient to open up, we can end up in a failure to rescue situation. We're talking about a violation of their most basic human need: safety. So getting this right, it's at the very core of what we do.
So, to really get a handle on this, we're going to use the nursing process as our roadmap. Think of it like a whiteboard game plan. First, we'll assess the clues, kind of like a detective. Then, we'll plan for safety. After that, we intervene with confidence. And finally, we'll wrap it all up with a quick recap to get you totally ready for your exam.
Okay, first up, assessment. This is where we put on our detective hats. Seriously, our job is to see what's not being said, to pick up on those signals that patients are often way too scared or embarrassed to tell us about directly.
Now, before we go any further, we have to get these two terms straight. They get confused all the time, but they're fundamental. Gender identity is what's on the inside. It's who you know you are. Sexual orientation is about what's on the outside. It's who you're attracted to. You gotta know the difference to even begin a respectful conversation.
And that respect, it starts right here. And this isn't just, being polite. This is a priority nursing action. Always ask for and use a patient's preferred name and pronouns. It is the absolute bedrock of trust. Without it, you're not getting anywhere.
Okay, let's get into the hard evidence, the things you can actually see. When we're assessing for intimate partner violence or IPV, the body tells a story. Look for bruises in different stages of healing. That's a huge red flag. Or injuries that just don't line up with the story you're being told. Even something that seems unrelated, like recurrent UTIs, can be a sign of sexual abuse.
And then, you have to watch the behaviors in the room. What are you observing? Is there a partner who won't let the patient speak for themselves? Or a partner who just will not leave the room when you need to do a private assessment? These are classic signs of control and a major warning.
And finally, we have the psychological cues. These can be subtler. A flat affect, where there's just no emotional response, is a classic trauma reaction. You might see a patient who suddenly withdraws from friends and family, or even physical signs of fear, like a slow, hesitant way of walking. You really have to be paying attention to catch these.
Okay, so we've spotted some red flags. Now what? We can't just dive in with a bunch of questions. We need a strategy, a framework. And the best evidence-based tool for this is the explicit model.
I love how this visualizes the whole process. The core, the absolute center of everything, is P for permission. You have to give the patient permission to even talk about this stuff. You could say something like, "A lot of people worry about their sexual health after something like this. Is that on your mind at all?" Once you've opened that door, then you can move on to providing limited information, maybe some specific suggestions, and if it's needed, a referral for intensive therapy. But it all starts with permission.
So, we've assessed, we've planned, now it's time to do something. This is the intervention stage. This is where we take what we've learned and turn it into decisive action and crucial patient education.
Now listen, if you only remember one thing from this entire explainer, please let it be this. Your number one, absolutely non-negotiable safety intervention when you suspect abuse is to get the patient alone. You have to find a way to interview them privately. A patient is almost never going to tell you what's happening if their abuser is in the room.
Let's switch gears to a super important pharmacology topic that you'll definitely see on exams: PrEP versus PEP. Here's how to remember it. PrEP is pre-exposure prophylaxis. Think pre for prevent. It's a daily pill to prevent getting HIV. PEP is post-exposure prophylaxis. Think post for after. It's an emergency medication you take after a possible exposure, and the clock is ticking. It has to be started within 72 hours.
Okay, now let's create a quick mental movie for an untreated infection: syphilis. Stage 1, you get a single, painless sore. If it's not treated, it moves to stage 2. Now you've got a rash all over, fever, swollen glands. Then things get quiet. That's the latent or silent stage. But it's not gone. Years later, it can roar back as tertiary syphilis, causing horrible damage to the brain and heart. Seeing it as a story helps you remember the progression.
We also have to be really mindful of how the medications we give can affect a patient's sexual health. Super common drugs, like the beta blocker propranolol for high blood pressure, can cause erectile dysfunction. Antidepressants can make it impossible to have an orgasm. So what happens? The patient just stops taking their life-saving meds and doesn't tell you why. It's a massive cause of non-adherence.
And that brings us to one of the biggest, most critical safety alerts in all of pharmacology. You absolutely have to know this one. ED meds like sildenafil work by dilating blood vessels. Well, guess what? So do cardiac drugs like nitrates. You put those two together and you can get a catastrophic, deadly drop in blood pressure. This is an absolute contraindication. It's a huge exam topic for a reason.
Ooh, okay. We've gone over a ton of important stuff, so let's pull it all together now. Let's boil this down to the absolute must-know, high-yield facts you need for your exam.
Think of this as your personal study guide. For IPV safety, what's the priority? Privacy, always. For STI prevention, the Gardasil 9 vaccine works best before sexual activity starts. For pharmacology, the big one, ED meds and nitrates are a deadly mix. Don't forget our older adults, they're at risk for STIs too. And for communication, what's the key that unlocks everything? Permission giving. That's the heart of the Plicit model.
And I'm just going to leave this quote here because it says it all. A patient will likely not admit to abuse if the abuser is in the room. Creating that private, safe space isn't just a nice idea, it's our absolute duty. So I'll leave you with this final thought. The signs we've talked about, the signs of abuse, of fear, of unspoken health issues, they're usually silent. They're whispers, not shouts. The real question is, after going through all this, the next time you see them, will you be ready to act?